Hey everybody, it is Friday at noon, so it's time for our novel coronavirus update for clinicians. I would encourage you to go onto menti.com on any device that you have, your computer, your cell phone, and enter code 393538 so you can participate in some of our questions for you. Since we don't have open lines and we just do chat box questions for this, it's one way that we can feel like we're engaging a little bit with the folks that are listening. So go to menti.com, enter code 393538, and you can go right on through the questions. You don't have to wait for me to move to them. You can enter them, your answers at your own speed, and there's only 4 or 5 of those that we look at each week. So I'm Dr. Michelle Fiskus. I am the Medical Director of the Vaccine Preventable Diseases and Immunization Program here at TDH, and we're coming to you from the State Health Operations Center, or the SHOC. And 6 feet to my right is Dr. John Benitez, who is Medical Director of Emergency Preparedness and Environmental Epidemiology and our Emergency Services Coordinator. So he is a liaison between Tennessee Department of Health and TEMA for emergencies. He's also a toxicologist, which is pretty cool. And Dr. Benitez had a scheduled deployment to the Middle East back in October of this year prior to this pandemic being announced, and then got stuck there for a little while and had to do pandemic response there in the Middle East. And so I thought it would be really interesting to hear some of his stories today. So he's going to join us in just a little bit. So the first question we have for you from Menti is, what is the hardest thing about this pandemic in one clean word? Isolation, fear, unknown, misinformation. Thank you for that. Sobering, frustration, finances, definitely, scary, tiring, PPE. PPE is probably one of the hardest things. Breathing, fear, unknown. Well, I think that's a good middle word for that. So thank you for all of that. Lots of fatigue and tiring and long. For those of you who weren't on last week, we told a little joke about why is it called a novel coronavirus, and that's because it's a really, really long story, and you know, this one's going to go on for a couple of years, and it's exhausting on all fronts. It is mentally and emotionally and physically and financially and everything exhausting. So we'd also like to know who you are. We like to make sure that we're tailoring the content of these presentations to the folks that are tuning in. So we want to make sure that we keep things relevant and interesting for you. So whether you're in pediatrics or adult medicine, whether you're a physician, nurse practitioner, specialist in public health, someone from college or school health, go ahead and let us know who you are, and these will continue to populate as folks pop on to the webinar. So menti.com, enter 393538 to answer those questions. And we usually see things fairly well split as far as physicians go between the adult and the pediatric folks, and then usually have a fair number of nurses and public health and sometimes school health folks on with us. And then we like to know how many of you are coming back. And so this has been a really encouraging number that folks come back and spend an hour with us every Friday over and over again. That helps us understand that that we're keeping this relevant and interesting for you, and hope that it's providing you some not only connection to other perspectives and keeping you informed on higher level issues than what you might be facing right in front of you, but making sure that it's worth that hour of your time, because we're all incredibly busy right now. So good to see that lots of you, the vast majority of you, have been here before. And for the 2 people who've never been on before, welcome, and we hope you find this interesting and that you'll come back next week. And then we like to get this little barometer on stress level. So are you good? Are you stressed but it's manageable? Are you pretty stressed and it's starting to take a toll? Are you really stressed, or it's bad and I really feel hopeless at this point? And These stratify by how you identified yourself in the second slide. So right now we've got all of the pediatricians responding, saying that they're frankly not doing real great. So these numbers have shifted to the right over the course of the pandemic. So take a look at this one real quick with 17 people responding, and then this is how we were in April. So in not quite 2 months, we've clearly shifted from folks who are doing well and stressed but are managing okay to this much more rightward curve, which is really I think it's very telling, and I think it makes sense just from, there's some other numbers, just from everything that we're seeing and feeling about this, the fatigue of it, the financial strain, the unknown. We like to control things, and we're not in a place where we're able to do that very well right now. So we want to make sure that you know that there are resources available for you. So the physician support line is one that's available from 8 a.m. to 3 a.m. 7 days a week, and this is staffed by volunteer psychiatrists who will speak to any physician who is experiencing stress and maybe just needs to talk to somebody for a little while, someone who understands their perspective on things. So be sure to jot that number down. And then last week we were asked, are there resources for non-physicians? And there are. So Tennessee has a healthcare worker emotional support line, and that line is available from 6 a.m. to 10 p.m. Through the week, and you can call that 888-M-HEART, H-A-R-T, TN number, and talk to someone. And these are also staffed by volunteer clinicians, and any healthcare worker who is on the front lines of this pandemic can call. So not just physicians, but also nurses and PAs and nurse practitioners and anyone who is working in healthcare and might need to talk to someone and vent a little bit about this and get some feedback and maybe some strategies to help cope with that can call this line. So for those of you who are new, when we first learned of first cases in the country, Tennessee Department of Health stood up its incident command system. So that was on January 15th, a couple of months ahead of our first case in Tennessee. So we are 156 days into our incident command system here, 106 days since the first case in Tennessee. And the interesting thing about this particular response is that typically when we have a health-related response with a communicable disease, the Tennessee Department of Health is the one who's at the front of that ICS and runs the response. In our case with this one, once the state declared an emergency, then by law, the control of that goes to TEMA, to the Tennessee Emergency Management Agency. And so they run the ball on this response now. And so we are very much a collaborator in that and help advise them and help advise the Unified Command Group where the governor and several of his folks, including our commissioner, sit. But TEMA has a huge place in this response in coordinating a lot of what we do. We still have our clinician call line that operates Monday through Friday from 8 to 4:30. That number is 615-741-7247. And we also have our physicians from the Communicable and Environmental Disease Group that are on call overnight every day. So if there is a public health situation and you need to call for advice from us, you're welcome to do that. So that could be animal bites, so possible rabies, or carbon monoxide exposures, or tests that come back that are concerning where you need assistance. You are welcome to call us. So globally, I've started putting up these week comparisons just to give a little bit of context. So we're up 1 million cases in 1 week across the globe, and looking at 3.5 million new tests in the United States. Deaths are up over 30,000 across the globe. And down on the bottom, you can see the epi curve. So these are the new case counts each day. The good news is they didn't have to rescale this for the first time in a while, but they did leave some room last time so that we could get up to 200,000 cases a day. So we are now rapidly approaching 200,000 new cases a day in the world. I imagine by next week they'll have to rescale this graph again to be able to have room for where we're headed. But this is definitely not a curve that is flattening across the globe, as we're seeing increasing cases in Brazil and Pakistan and India and some other countries that are really just beginning to surge their cases. Some good news is that, according to the CDC, U.S. adults are reporting that 88% of American adults agree that we should be keeping 6 feet apart, 82% agree that we should not be in large groups, and 80% support stay-at-home orders and non-essential business closures. So we do, although it doesn't feel like it some days, we do have overwhelming support for the strategies that we've employed. It's just that 12% might be louder than the 88% that are quietly doing what we've asked them to do. United States case counts were up 160,000 since just last week. Total deaths are up by another 5,000 this week, and you can see this increasing curve over time that we continue to move in an upward direction. This is my favorite data map, and this is out of Johns Hopkins, and lists all of the states. So if you're green, the darker the green you are, the better shape you're in as far as dropping the number of cases that you're seeing each day. You see Washington, D.C. is in pretty good shape, Virginia, Maryland. The brighter pink you are, the worse shape you're in. So Arizona, Oklahoma, Alabama, Florida, Texas are not in a good place right now, and we're sort of in that medium shade of pink where we would like to be moving towards green. We've kind of been stuck in this shade for a while. From a statewide perspective, we post these numbers every day at 2 o'clock out of Tennessee.gov/health, where you can go on and look at this and many more data points. So our cases are up to 32,800 as of yesterday. So we're still continuing to climb those numbers. You can see in the heat map there where the hot spots are, which is Shelby County, which is the Memphis area, Nashville, Davidson, Rutherford County, Hamilton County, which is where Chattanooga is, to a lesser extent, Knox County. Northeast has some of the lowest counts, which is great, and we've got pretty low counts in the western part of the state. As long as you're pretty far east of Shelby County, those folks seem to be doing okay. Here's our state epi curve. So I've marked where you can see where the stay-at-home order began and then where the stay-at-home order ended, and then you can see this continual rise in the 4-day average of new cases, which is the red line that's going up, and then the number of daily cases also going up. So the trajectory of this curve in Tennessee is not what we would like to be seeing right now. This is a new chart that's being put out by some of our data folks who are absolutely amazing. So this is active cases by county. So I've got Knox highlighted here. There's Davidson. There's Hamilton County, where Chattanooga is, and Shelby County. And so you can see their epi curves have really started to move up. Davidson County had a little bit of a plateau and seems to be on the rise again. And then some of the other counties have much smaller populations, so a small increase in case counts can look like a really big increase on a chart like this. But you can also see the counties that seem to have leveled off and might be in a little better position at this point. And then this is our hospitalization data. So this comes out of HERTS, which is reported by the hospitals across the state to the state on an ongoing basis every day. And so our COVID positive hospitalizations have steadily increased, starting at sometime around the end of May. And then our ICU patients have increased steadily. We were consistently around 100 ICU patients. Now we're rapidly approaching 200. Our ventilator numbers used to be solidly in the 60s. Now we're up into the 80s. So again, when we're looking at moving into opening schools, opening colleges, moving into flu season, which will be upon us faster than any of us would like, it's concerning that things are moving in the direction that they are for our hospitals. So we do have two alternative care sites that have been stood up with assistance from the Army Corps of Engineers. One is in a former newspaper factory out in Memphis, and that has about 400 beds and is ready to go for surge. The other is at Nashville General Hospital. I think they've got maybe a couple hundred beds over there. And if you tune in next week, we're going to have Dr. Paul Peterson, who is also with Emergency Response, who has been integral in setting up those alternative care sites, and he's going to do a little bit of a deep dive into what that has looked like setting those up and how they've been preparing for surge, which we may see in the coming months into flu season. We talked a little bit last week about how long-term care facilities were going to be able to start allowing visitors back in, and they had to meet a few criteria. So one is that they could not have had a new case in their facility in the past 28 days, and another is that they have to have below a certain threshold of new cases in their county. So that threshold has been set at fewer than 10 new cases per 100,000 residents of that county over the past 14 days. So you can see from this map which counties, which are the vast majority, are below that threshold at this point, and which ones are above. And not surprising given the burden that they have, that Shelby County, Davidson County, Hamilton County are among those that are not in a place yet where the governor is allowing for them to have visitation in those nursing homes. So that started on June 15th, which was just this past Monday, and they'll have to continually monitor those county numbers, which are posted on our website now. I put that website down at the bottom there, where you can pull that up by county and see what your threshold looks like where you live. We've had some pretty significant collateral damage because of COVID-19 around vaccination rates, and sorry, my slide didn't travel well here, but we've pulled the data from TENIS, which is the Tennessee Immunization Information System, and all of the children who get VSC vaccines, and then a good number of the children in Tennessee who get privately insured vaccine have their immunizations recorded in TENIS so that they can have a lifelong registry of their immunization information. So you can see in April we took a pretty heavy hit where we had this perfect storm of parents being afraid to bring their kids in. They're trying to comply with the stay-at-home order and not make unnecessary trips. Doctors' offices really not quite knowing how they're going to see sick kids and well kids both, and protect them and protect their staff, and needing to be able to acquire PPE that they didn't have, and then public health being diverted to needing to respond to COVID-19 with contact tracing and case investigation and providing drive-through testing. And so we lost that safety net for a little while of people who were able to provide immunizations to especially the most vulnerable children that we have who may not have access to insurance. So we saw a big dip both in the 0 to 2-year-olds in April, and then a bigger one in all comers, so mostly adolescents, where we saw 43% fewer immunizations in April 2020 versus April 2019. So it's encouraging that May looks to be coming up a little bit closer to baseline, but that doesn't mean that we've caught up all those people that we missed. That just means that we're getting closer to being back to where we should be on a monthly basis. So we really need to get these numbers far above baseline where we were for any given month in 2019 if we're to be able to say that we're catching these kids up. I like to always give you some updates on what's going on in the news. So the randomized evaluation of COVID-19 therapy study out of the UK, are called Recovery. The Recovery trial is a large randomized clinical trial out of the UK where they have enrolled 11,500 patients from more than 175 National Health Service hospitals across the United Kingdom. And they are doing randomized control trials on a number of different types of potential therapies for COVID-19. So They did release a statement on Tuesday of this week that was a study on dexamethasone use. So this was a study of 2,100 patients who were randomized to a dexamethasone arm of 6 milligrams once a day for 10 days, either given PO or IV, and 4,300 patients who were randomized to standard of care. And what they found was that there was a significant reduction of about 33% in the dexamethasone trial for those patients who were ventilated from COVID-19, about a 20%, 1 in 5 reduction for those who were requiring oxygen therapy for mortality outcomes, and then no difference for those who were experiencing no type of respiratory need at the time. So it's promising, it's early, and obviously dexamethasone is something we've had in our arsenal for a really long time. It's cheap. As of today, it's still widely available. But again, the benefit here was for those patients who are in an intensive care unit, not for any kind of pretreatment or prophylaxis. And we know that actually giving steroids at the onset of COVID-19 can actually be detrimental to those outcomes. So these are the patients who are experiencing that storm of inflammatory response that comes after their immediate infection with SARS-CoV-2, where steroids can help maybe attenuate that a little bit. So on the 16th, they came out with, woohoo, dexamethasone, and on the 17th, WHO releases caution on calling this, a breakthrough for dexamethasone, just because the data is early, and I think WHO has maybe learned some lessons about releasing statements that make let's say, strong opinions, potentially a little too early. So that may be why WHO has come out with this response. In other news, WHO has ended their trial of hydroxychloroquine as a potential treatment for COVID-19. As we've seen in study after study, there just has not been evidence that hydroxychloroquine has any benefit in treating patients with coronavirus. There are still some NIH trials going on for prophylaxis and for early treatment, but WHO is ending their trials on that. So I want to bring on Dr. John Benitez, Colonel, is it Dr. Colonel, Colonel, Doctor, just never put them together, John.
Good afternoon, everyone.
And I just wanted to invite John to come talk to us a little bit about, what you thought you were getting into versus what you really ended up getting into over the course of your deployment to the Middle East. So thank you for taking a little bit of time. I know you're just like fresh back.
Yeah, fresh back and trying to get reoriented to life back in the States, or CONUS, as I'll mention it in a slide or two later.
Yeah, I learned, I love putting together these webinars because I learn just as much as the people who listen to them. So I had to, I was Googling military acronyms last night, which is not always easy, but there are all kinds of things that you threw at me. And CONUS I did figure out, but I didn't understand the context of it. So you'll learn some of those acronyms too. So John is also an amazing photographer, because some of these pictures are absolutely beautiful.
Well, do maybe not all.
Yeah.
Anyway, so this is just a picture just showing us outside of camp. Beautiful sunsets there, and I mean the main thing there is that there's always a constant wind. Probably minimum is easily 10 miles an hour for every day, if not 20 or 30 miles an hour. And the sand kicks up by end of day with the heating of the day, and the dust really gets picked up. And so there's all these little particles in the air, which means at sunset time, it really lights it up, if you will. There's a few clouds. Some of those clouds are not always clouds, they're actually dust. The thing you see way in the horizon, almost obscuring the sun, that's actually dust. That's not cloud.
And is this in Kuwait?
This is in Kuwait.
Okay.
Yeah, my main base was in Kuwait. I did get to travel to several other countries because I was in a group that was in charge of all the medical care for the Army, but the military in general, for about 8 countries, and I was the public health officer for that.
And so what were you supposed to be doing over there?
So what I'm supposed to be doing there, if you want to learn acronyms, I'm supposed to be tracking DNBI, which is disease and non-battle injuries, and trying to prevent those and develop controls, whatever that we need for that. So I'm monitoring DNBI, disease non-battle injuries, keeping track of, rabies, because there's a lot of rabies exposures, not necessarily rabies cases. Some of the other dogs might have the rabies. But, that, we're looking for sexually transmitted diseases, looking for the influenza-like illnesses, et cetera, et cetera. And so that's what we're tracking on a normal day. So my normal day up until about January was really some HIV, some hepatitis B, rabies. I actually chair the rabies board for the whole Middle East and have to keep track of everything that's being taken care of appropriately in those cases. So that was my normal stuff.
Wow, that's really, and so did you hear about the initial Wuhan cases back in November or so?
Well, I didn't hear so much in November, so it was either sometime in December, early January that I was starting to actually work out plans, started to work out some white papers for our command just so that they would know what was going on and how bad did it look, what we think, and just to start being ready. And I was traveling quite a bit in January, February, and then also when I got back early February, it was like, okay, we need major plans.
And then things shifted for you.
Yeah, because I was supposed to be coming back or leaving there sometime in March, early April, and then I ended up with what we call amendments to our orders. How much they extend up. They ended up with a total of 5.
Nice way to say it.
5 amendments, and I kept getting delayed, and then finally got back to the U.S. Of course, coming back to the U.S., there may be a picture of this at the end. I have to go through quarantine myself to make sure that I'm not bringing anything, back from overseas.
So this is just where you were supposed to be?
This is one camp in Qatar. Again, it's a multinational force, so there's not just U.S. troops, but we have forces from all over. Our headquarters, the medical, was in Qatar. By the time I got there, I got based in Kuwait because it was being moved from Qatar to Kuwait. So I was one of 3 people initially in Kuwait, and then the rest of the people joined us, and eventually we had about 100 people in Kuwait after we moved everything out of Qatar.
And these are all public health folks?
No, this is all the medical command. So I think of it, it's not really public health, but we're looking at all the resources that all the medical people may need, whether it be a hospital or just medical units attached to an infantry group. Just supply logistics, planning for what do we need to plan as we move, different units across. Of course, the Iranian crisis came in, so we had to then plan with things as to how do we move troops and what have we done pre-stage for moving medical assets around based on that. So there's a lot of activity going on at that time, which includes the public health part of things. So. And just to kind of give a view of what, town, if you will, is like, this is, again, back in Qatar, but the city, which is where the majority of the population lives, I'm guessing, depending on the specific country, anywhere from 70 to 90% of the population lives in the big cities. So this is the capital of Qatar, which is a small, country, but it's a very modern-looking place, as you can see from this picture.
Yeah,
and again, the World Cup is going to be there in about 2 years.
Oh, so. Well, yeah. But you are not in the city. You are.
I do go to the city for a little bit of shopping. I mean, most of the time prior to the COVID starting to shut down, countries, cities, et cetera, we can go to town and go shopping and do that kind of stuff.
But could you see this from where your camp is?
No, I'm here on a boat on our way to an island to have a beach day off.
Oh.
So.
Yeah, it looks lovely.
Yeah.
And then this is reality.
Inside camp, the view from the office on the way home is really this. Again, the beautiful sunsets, but again, there's concertina wire, there's security precautions, places that people can walk into or not, depending, again, on your background and security clearance. And then again, one of the countries that we're involved with was Saudi Arabia. We're starting to move some military assets into Saudi Arabia, which then means we need some medical backup for these folks in case they get hurt, injured, or otherwise. Again, whether it be battle-type injuries or the non-battle-type injuries, we need to send that. So we sent a team down there. We moved a group from the U.S. that came in to supplement us that could provide care and set up a limited care hospital, if you will. They can keep somebody there for 2 to 3 days, but otherwise they would need to be moved on to elsewhere.
So is this because of the pandemic that you did this?
This is pre-pandemic, believe it or not. If you recall, back in the late summer, fall, there were some missiles and drone attacks on Saudi Arabian oil infrastructure, and the Saudi Arabian government asked the U.S. government for help in assisting with all that.
I gotcha. Okay, so had it not been for that kind of crisis happening, you wouldn't have been there. So this was not in your original mission when you went over.
Correct.
This came up.
Something new that came up. There's always something new. Some of them based on the politics of the time, the military actions that are going on at the time by other countries, so. And then there was an outbreak at one facility of a very super resistant bug. We're about to publish this paper, so I can't say a whole lot about it. But
it's a super secret classified bug.
Not quite, but it will be published again in the medical literature. But got to visit this hospital, which is actually what we call a Role 2 medical treatment facility. Again, it's a limited hospital staff with physicians, nurses, et cetera, but they can hold people up to about 3 days. They do have ICU bed capacity. They can do surgery, but again, it's in a limited capacity, and then they have to move people on. But I did get to travel there, visit, participate with some of their stuff, give some instruction there, and evaluate things overall, which is sort of my mission from the public health, preventive medicine.
And so these facilities are just for military. They're not for
just for military. Again, there's rules of engagement. It depends a little bit by country, but in general, the military facilities are for our military, meaning the American military, and their allies. You can use them for contractors. Typically would go to the normal civilian facilities. Again, if it's a life, limb, or vision thing, yes, we can take out those emergencies, but then we move them on to elsewhere for that.
Was there a time where you began to identify coronavirus within any of those populations?
Yeah. In general, no. We were successful, and as of today, at least the main camp that I was in, we successfully kept out all COVID. We did have several contractors that did contract it, but I almost thought it was funny saying that.
It kind of did.
But most of the contractors pretty much live in town, so they caught it in town where there was much more of a big uptick in COVID. And that's when we started having to make decisions and advise the camp commander of when do we shut down camps and not allow anybody to come in or out of camp. And again, being a military installation, you can never quite 100% shut it down because then you shut down mission capabilities. But we can certainly shut down contractors. And, for example, you think about fuel, water, food, deliveries as well as, just cooks and that kind of stuff normally is done by contractors. So as we have to make a decision whether to then base them on base and just keep them there, keep them in quarantine first to make sure they're okay, then allow them to work. And if we cannot do that, then they stay in town and then they can't work anymore, which means that we, the military, have to take over those duties. And how do we do that? So that was a big part of my job. For example, my one camp, I became the public health emergency officer once the pandemic public health emergency was declared. Then I advised the camp commanders to what to shut down, when to shut it down, and then he either took my advice or didn't, but basically I strongly advised where I could.
Yeah, it's kind of like here. So did you have to shut down any of the camps?
So the only camp that we truly shut down, well, we shut down several camps to contractors, yes, across multiple countries. One of the first countries where we had cases, we had at least one or two military that may have caught COVID. It was brought in by a contractor, so that one was shut down, pretty quickly and pretty early. We then had to develop isolation quarantine, or not because of that, but we already started developing that, but enhancing it, I guess, is a better term, isolation and quarantine facilities at every camp, so that as anybody got identified, they could quickly be isolated and all their contacts traced and put into quarantine. That was a big part of our job.
Yeah, it's huge, just logistics of all of that when you've got limited space and limited capability.
Well, then you hear that they're going to move again, I said a lot of people move through our camp, but they're going to move, 300 troops from Afghanistan to Kuwait to then on their way home or wherever else they may be going. It's like, okay, where do we put 300 people all of a sudden?
Yeah, away from you.
Away from us. Keep them totally contained, meaning food, water, shelter, bathrooms, et cetera. Because
great thing. So did you have on-site testing capabilities?
Well, we started to initially. We had the machinery. We were developing we just needed some reagents to develop that. We already had that equipment there. The reagents took about 2 months for them to fully get up to us, but we only had permission because our lab is not a CLIA certified lab. We could not run diagnostic testing, same test, but we could do surveillance testing. So for true diagnostic testing, we had to wait for additional machinery to come in. We installed it at the hospital, did some shifting that way, and then we could start doing it. But it did take a little bit longer that way. And then, of course, we had lots and lots of meetings with the Ministry of Health, with the regional health departments, and just to coordinate our responses. Initially, the local departments were helping us with the testing. They would help us with our contractor population. In other words, if we found a positive case, they would have to stay in their apartment, their building, their city block. And so city block by city blocks, the city clamped down and put them in quarantine. And that created a lot of interesting issues if there's time we can talk about, but it was just a matter of, you know, how they actually were shutting down the city by who could move out of certain parts of the town. Again, we did it by just saying you can't come back into camp if you have a positive case, and only upon further testing and, you know, running through the course of it.
But they would actually identify a block and say,
yes.
Okay,
then we just close the block as opposed to really trying to trace it individually by individual context.
Which is kind of what happened with Zika last year, year before, in Florida, where there was a zip code or a specific blocked area where, okay, this is the Zika transmission zone, we think, and nobody should go in or out of here if they have risk factors.
And that's why it was interesting too that the national population of Kuwait, the true nationals, is much smaller than all the other nationals that live there, that are contractors will live there to help, you know, with the economy there. And so they had specific camps, or in some cases there were resorts or hotels that they reserved for their nationals, and those were their quarantine quarters for those. But if you were not a national, then you stayed, they closed down your block, and that's where you had to stay.
Oh, okay.
So there was a little bit of distinction between if you are a Kuwaiti.
So that's if you're a Kuwaiti who had to be quarantined or isolated, you got to go to a resort?
Yes.
Oh.
So if you were, isolation didn't really exist initially. Isolation meant you were in a hospital. So that would do with everybody.
So if you're quarantined,
it was either a resort or it was your old city block, and now you can't move and all your neighbors can't move.
And when you ended up having to shut down some of the facilities that you all had, then you couldn't go to the beach either.
Correct. We shut down camp. We couldn't leave. Only mission critical things that we could leave. There's only select few that, you know, could do that. So basically, we lost all of our. If you think of USO, you know, people support for troops, we had no more movie theater. We had no more just activities. They were shut down. The gyms for soldiers, those got shut down. So for fun, you got to stand outside or go to your room. Okay. That was it.
Outside in the dust, or inside not in the dust?
Or in the heat. Or
and what's the temperature like there?
Well, it varied. I mean, the wintertime, nighttime can be in the 30s, daytime 60 to 70s. As it started getting warmer, by the time I left in April, it was up into the 90s. Daytime, nighttime at least cooled down somewhat to the 60s.
But it's a dry heat.
We were relatively close to the Gulf, so it's
not
pretty
so much.
humid, so yeah. You know, there's several, you know, in the camps we still have classrooms. I mean, there's still ongoing teaching for different things. This is one of the labs or classrooms for IT instruction for all of our IT support. And so I had to go assist the command surgeon for the camp, since I was the only public health person there, to say, okay, what's the appropriate social distancing in the classroom? So we're taking notes through it, you know, measuring distances, and then giving suggestions for what could they maintain open or how many spots they could actually, you know, man at the time. And then coming back to CONUS, again, continental U.S., as opposed to OCONUS, which is outside CONUS.
Okay, so this is when you got back home.
So when I get back home, I got to, along with all, you know, people that I travel back with, they put us up in these tents. These are just tarp tents with 50 people in each, men and women together. And again, cordoned off on the outside with a very restricted area where you could move, and your food got delivered to you, and then we served ourselves, you know, for food, and we spent 2 weeks there until we were declared clean. Temperature checks morning and afternoon, and
this was in the middle of the desert.
This is in the middle of the desert. Yeah.
So this is air conditioned?
This is air conditioned. Yeah, absolutely.
But yeah, there's not a whole lot going on in there.
Well, you can see how excited we are. We're just sitting on our bunks and either working on a computer if you have one, or your phone, or take a nap, or a few could go run around the tent or walk around the tent for exercise. But there was not a whole lot much else.
I bet you know how many tiles are in that tent.
Just about. And then after every dust storm, because we had about 3 major ones while we were there, the dust just sneaks in and almost ripped the doors off of this place. And we had that gray-looking floor, tan gray-looking floor, was red. It was a red dust from the desert there. So
that sounds
major cleaning of your bunk, your equipment, the floor and stuff.
We had nothing else to do.
Nothing else to do.
But it probably do people have laptops in there?
Yeah.
How do they survive dust storms like that? You just know it's coming and bury it
Put them away and
yeah. Oh wow.
And then again, this is back in I believe this is Kuwait, but just again the beautiful sunset.
Yeah, it really is beautiful. All right, well, thank you for all this. It was really interesting to just hear another perspective. And did you, when you found out that they were declaring a pandemic, what was the kind of the overall sentiment there? I mean, I know y'all kind of roll with stuff, but
from our role in the medical community, there was like, well, yeah, we've been talking about this for a couple of months, and no big deal. We just kept up with the numbers as to what was happening in town, because we basically had to decide, and that was one of my sort of first jobs other than developing isolation quarantine facilities, because we had essentially room for 24 people. We expanded that to 1,500 people that we could do if we had to, because we didn't know what kind of numbers we're going to see. And this is just per one camp. We did this across 8 countries for multiple camps.
So you built these
isolation
well, your mission was to go to all of these countries and build these
at least talk to the people that are already there and making sure that they had them.
And then you had to go back and expand capacity in all of them for surge.
Correct. Because, I mean, normally, you have your influenza-like illness. You may have other GI bugs that you want to isolate people or, quarantine them. So, but those are usually small numbers because we catch them early and they're a little bit easier to track.
Yeah.
Here, all of a sudden, we have something that's going to be much more contagious. We didn't know how much or how bad and how many people we might get if it truly got loose in camp. Remember, about that time, South Korea made the news quite a bit where it contaminated a couple camps, and it's creating a lot of havoc for them. So we just wanted to really keep on top of that and not let things get out of hand.
Well, it's wonderful to have you back. We missed you because that was a really long time for you to be gone, and I think it's also good for folks to understand the kind of expertise that we have at the state public health department, because we don't always get to kind of brag on the type of experts that we have here working on all of this. But it's wonderful to have you, and obviously you have an amazing breadth and depth of experience and dealing with things and being able to kind of shrug at the onset of a pandemic and say, well, we've prepared for this, which we have for many years, since 2009 and before and after. So, well, we want to get to your questions. So, first we have a PPE question up here. So, do you have PPE? If you do, what do you have? So, I mean, we're still looking at pretty not great numbers of PPE, although it looks like maybe the gowns have gotten, that's gloves. No, gowns haven't gotten any better. I just need glasses. So, have you used Survey 123 to order PPE? So, we've got a good number of folks that have ordered, and then of those folks, how many of you got it? How long did it take? So we've got the majority of people still saying that they're getting their PPE in under 10 days, which is great. So we continue to share this feedback with TEMA so that they understand how that system is working, especially for frontline folks. If it has been more than 10 days since you put in a request for PPE, then go ahead and put in another one again through the survey, and just make sure that you continue to ask for it. Give it about 10 days or so, and if you haven't heard back, then enter that back in. So we're going to answer some of your questions here, and thanks for sticking stuff into the survey for topics for next time. So we'll make sure that we address some of these. School is a huge issue, and we're waiting on some guidance to come out from Department of Education to help with that, and we hope to be able to send out our own guidance pretty soon about specific response. So hopefully we'll be able to share that with you next week, and also get that out in emails and through the TNHON and other ways that we notify you of things. But continue to put those topics up there for us. So here's some questions. So Tennessee is listed as having increased cases. where are the hot spots, what's leading to them being hot spots, and what is the ICU bed status in these areas. So I don't have the granular ICU bed status for those hotspots right now in front of me. Those hotspots are largely the big metro areas, which makes sense. You have more crowding, you have more visitors, you have more workforce coming and going, more opportunities for spread. We also know that that the minority populations are disproportionately affected by COVID-19. So those metro areas also have higher numbers of minority populations, and the reasons why they're more affected are varied and existed for a very long time before COVID ever came on the scene. So it's really shining some light on some of those disparities that we have around access to medical care, around housing adequacy. We have multi-generational homes, in some cases because it's a cultural preference, in some cases out of necessity because there isn't affordable housing. There may be more crowding, there may be some problems with getting messages into communities about the importance of masking, or there may be fear around cooperating with public health and assisting us in identifying contacts for fear that they might be turned over to immigration, or for a while we were having to report the positive list to the police, and so there may have been some hesitation to go in and get tested for fear that you might end up with a notification being sent to law enforcement about that. So there's lots of reasons why the metro areas, and just plain population density, why they have hot spots. There's also more public transportation there where there's opportunities to spread on closed buses as people travel together for, potentially long periods of time. Is it true that telehealth visits will no longer be reimbursed? Can Department of Health help get this message that cases will increase the more people have to come in potentially? I had seen something very briefly yesterday about telehealth visits, and honestly did not have an opportunity to go back and read about it in detail, so I'll go look at that. I know that there had been some time constraints put on reimbursement, specifically from TennCare, that was to end the end of May, and I had not seen any communications to suggest that that was being extended, but I also don't know that it hasn't been extended. So we will look into that and get back to you about that. This one's for you. What's the incidence of COVID over in the Middle East? I've heard Saudi contacts that the disease is spreading quickly.
Yeah, I think of all the countries in the Middle East outside of Iran, Saudi probably has the largest increase and largest number. I believe per WHO they were in the neighborhood of about 150,000 range of positive cases. I don't remember the cases that have died, but they're certainly at least over 1,000, if not more. They've had, again, a lot of the population lives in the big cities, not in the desert, the open areas, if you will. They have canceled the Hajj. They have canceled a lot of the religious pilgrimages that they normally have, or should have already happened, but they canceled that because of importing them from all over the world. And so, they're definitely very worried about that. So in general, the Middle East is hard to tell in some countries. One, there's wars or rebellions or such going on in many of these countries, and so the data that come out look low, but it's suspiciously very low because it's just not being tested. You don't have access to care. You don't have access to testing. You don't have access to even think about testing in some cases. We know that the big splurge that did occur early in Iran, of course, crosses over borders, with their military, with a lot of the conflicts there that they're involved with. So that's where a lot of the spikes came into, especially into the Iraq and Syria arena that we were looking at. And again, even the numbers there, based on the public health infrastructure, are very grossly underestimated right now.
Like ours, probably.
Probably worse than ours.
Worse than ours. Next question, how well equipped is Tennessee's testing capacity for all the nursing home testing for every employee? So some of you may know that an order came down from CMS that every nursing home in the country has to have all of their staff tested every week for COVID-19. And so in Tennessee, we will have all of those nursing homes tested at least once before the end of the month. So I think there's just a small number of nursing homes that are left to test over the next week and a half before the end of the month. And then those nursing homes are required to get testing for their staff every week after that. So there's a variety of ways that they can do that. There are lots of private laboratories that do testing, that most of those nursing homes are already contracted with some private laboratory that is likely doing COVID testing. The state is also in the process of procuring different types of test options that can be deployed to those nursing homes to assist with them. But there's no question that it increases burden on and some constraints on the testing capacity across the state when that large of a number of folks have to be tested on a weekly basis. And so all of those labs are scrambling to increase capacity, to acquire more high throughput testing platforms, and to try to onboard new types of testing platforms to be able to meet that capacity. The other concern is as we move closer to the opening of college campuses, that many college campuses will require or encourage testing among staff and students, and that will also place strain on a finite capacity that exists in the state to get those tests processed. So there is some backlog right now. There had been 24 to 48 hour turnaround from most of the labs. Some of them are looking more like 2 to 4 days right now. We're hearing some reports of even 7 days right now. And so, looking ahead, there's certainly a chance that those turnaround times for testing are going to increase, which obviously is not ideal when we're trying to identify positives and get them isolated and get their contacts quarantined. Next question, are the nursing home positives from the mass testing over the past few weeks being reported if there's just one positive in the facility? So I am not the nursing home testing expert, but I believe the numbers that we report are for 2 or more cases in a facility, and those are listed on the website, but I don't believe that they're being reported on that list if there's only one identified isolated case, either in residents or staff there. Best way to urge parents to keep up vaccines for children. So this is critically important. We've got back to school coming up. We have no intention of changing any of the vaccine requirements for school entry, so it's very important that those kindergartners and 7th graders are getting in as a priority to get their vaccines updated. And then obviously those children 2 and under should be the other priority, and they've kept up fairly well. At least we've not seen the kind of declines that we've seen in the older kids. But we were just starting to make headway on things like HPV vaccine, and in April that was down 65% from April of 2019. So our ability to get kids caught up for things like HPV vaccine is really going to be challenging. So the best way to urge parents to come back to the offices is to reach out directly to them, do reminder recall to let them know that they should come back to the office. Can you make phone calls, send postcards, send letters, send text messaging to them. If you use TENIS, the Tennessee Immunization Information System, there is capability in there to be able to send text messages, robocall messages, to print postcards that you can send out to patients who are due. You can look up through the forecasting there what patients are due for which immunizations and send out reminders to those individuals and ask them to come back into the office. I think what the parents need to hear is that vaccines are important, vaccines are safe, vaccines are effective, and that you can provide that service in a way that's safe for those patients. So either you're seeing ill patients in the afternoons or only in one location, or making sure that there's physical distance between where you're seeing sick and well patients, keeping patients in the car until you call them in. Do you go out to the car to immunize them? You can do that too. We've got guidance on our website about how to do curbside immunizations. So You can do histories with them over text or phone call if they're out in the car, have conversations, give them their anticipatory guidance. You can send them electronic copies of the vaccine information sheet, send someone out in some PPE to protect them from a screaming child who could be an asymptomatic carrier, give them shots. In some ways it's easier if they're strapped into a car seat, and then send them on their way. So there are ways to get this. Use social media, get your messages out promoting your practice that this is safe, you can come in. We encourage you to do that. And then additionally, the health departments are getting back up to capacity with their regular services. Everyone is supposed to be back up to capacity by July 1st in all of the counties. So they'll be back to immunizing children as well. So if you don't have the capacity to do it for whatever reason, then you can always refer them to a local county health department. Here's a question for you. Is the U.S. military helping the locals in terms of testing and whatnot?
I mean, the answer in general is no, but it really depends on the situation, who's asking for help and how. So in areas where there's some active conflict, we're helping the locals, and we're trying to, again, winning hearts and minds, where you're helping a local town, local chief, local whatever the right term is. They may be doing some of these things along those lines, whether it be just medical care, maybe some specific testing, but otherwise, no, we're not doing that in general.
Do we have data on ivermectin for inpatient or outpatient use? So I do not have information on ivermectin, and I will get that in next week's presentation. How is the number of contact tracers in the state of Tennessee being addressed? We are still inadequate. So yes, there has definitely been a bandwidth issue when you've got thousands of cases, especially in metro areas, that are being identified, and a finite number of public health staff who can run that tracing while they're also trying to maintain the services that we offer in the departments of health. So the state has contracted with a third party to help do contact tracing, and as of yesterday, I believe we had 175 new people who were doing contact tracing, and I believe they're still onboarding more of those individuals. So we should see a significant improvement in the number of contacts that are being followed up with over the course of the next couple of weeks as those new folks have come on board. Next question, is the at-home collection test an okay thing to recommend for people to use? It is run by LabCorp, and it looks like it's a PCR nasal swab. So there are several companies that do offer direct-to-consumer testing. LabCorp is one of them. They have a platform called Pixel. There's one called P23 Laboratories. There's one called Everlywell. Quest is bringing one on board pretty soon. And so an individual would go online, set up an account, and in all of these cases, they have to answer a questionnaire asking about their symptoms or their exposure. So they do require, in all of those cases, as far as I've seen, for there to be a qualifying reason for them to be requesting testing. Then they ship that test kit to the individual in their home. They swab their nose. They return it back to the lab within 24 hours. And most of those have a 48-hour turnaround time, where the patient then goes on to a portal and pulls down their results. And then most of those labs communicate with the Department of Health electronically, so we get those positives and know to report those in for isolation and contact tracing. I haven't seen specifics on at-home collection metrics. So we know that the PCR platform that they run is the same one that they run for their other testing. So high throughput PCR tests that have FDA emergency use authorization and are generally good platforms, similar to the ones that we use at State Public Health Lab. The breakdown is in the collection of the specimens. So these are usually nasal swabs or saliva tests. There's not a whole lot that's complicated about spitting into a small tube, but I haven't seen a lot on the specificity or sensitivity, more importantly, on saliva testing. These are nasal swabs that are self-collected, and so, again, depending on where the person is and their symptoms, what their viral load happens to be at the time, how aggressive they are at getting that swab up there to do a collection properly, can significantly increase or impact the sensitivity of that test. So it's in a perfect is the enemy of good world is a test that is done better than a test that isn't. Probably is, but you do have to consider false negatives. So if you were on our webinar last week, we talked a lot about the limitations of false negatives in PCR testing, and Dr. Kara Levinson from the State Public Health Lab and I had a really in-depth conversation about that. There was an article that was just published in the New England Journal that's specific about that, and the importance of understanding that if the person in front of you is symptomatic and has had an opportunity for exposure and has a negative test, you should probably believe the person and not the test, and maybe test again. But if they have little opportunity for exposure and they have no symptoms and the test is negative, you can probably put a little more faith into that negative. All of our webinars are archived on the tn.gov/health website. Go to the yellow bar at the top for coronavirus updates, and then go to the provider box, and you'll see both the link to register for next week's webinar and also our archived presentation. So if you want to go back and look at that one last week, June the 12th, we go into a really in-depth conversation about lab testing and the power of false negatives in that, and it starts about halfway through that presentation. And it is 1:01, so I hope to see you back next week. So next week, if I have my say in it, I will be holed up somewhere in a cabin without internet access. So next week we will have Dr. Amelia, thank you, Keaton, sorry. Dr. Amelia Keaton, who is the Deputy Medical Director for our hospital-acquired infections program, and she has headed up a lot of that nursing home testing issues. She'll be on in my place, and then with her will be Dr. Paul Peterson from Emergency Preparedness, who will talk about what's going on with the alternative care centers that have been stood up, so you'll get some information about that. The following week is July 3rd, and so we're going to take that one off altogether and come back again on July the 10th with our next webinar. So look for archived presentations on the website and our ongoing Q&A. I know I'm behind on getting that updated because COVID, and I will try to get that done as soon as I can. And take care, have a great week, and I hope you get a weekend. Take care, and thanks to you, John, for being here.
Always willing. Thank you.